Patients with AML have a number of mutations that are recurrent, meaning they happen in patient after patient. One of the most common mutations are in a gene called FLT3. The most common of those mutations is an internal tandem duplication, or ITD mutation, and this is associated with poor prognosis because it increases the rate of relapse. If patients relapse and they have a FLT3 mutation, they really do quite dismally. And there are actually two types of FLT3 mutations that we see commonly. In addition to the ITD mutations, there are also tyrosine kinase domain, or TKD mutations. And the importance of that is not so much for prognosis, but because the presence of a TKD mutation may render patients sensitive or insensitive to various different inhibitors of FLT3. Now, to date, the only drug that has been approved as a FLT3 inhibitor to treat AML is a drug called midostaurin. That's not a selective FLT3 inhibitor, but it does have activity in this patient population and against that target. But drugs that directly targeted FLT3 had shown some hints of activity, but had not proven themselves to be better than standard therapy in terms of approved agents. So the rationale behind the ADMIRAL study was to test gilteritinib, which is a potent and selective FLT3 inhibitor, against standard chemotherapy in patients with FLT3 mutations that were detected at either first relapse or amongst primary refractory patients with AML. And this is a phase 3 study with the primary endpoint of overall survival. Patients that were eligible for chemotherapy, either for high-intensity chemotherapy or low-intensity chemotherapy, who were randomized 2-to-1 to either single-agent gilteritinib, which is, again, an oral tyrosine kinase inhibitor, generally given in the outpatient setting, versus what their investigator felt was the most appropriate salvage chemotherapy choice. And there were two high-intensity regimens, either FLAG-IDA or MEC, so again, intermediate to high-dose Ara-C-based regimens, or they could receive either azacitidine as a single agent or low-dose cytarabine as a single agent. And once randomization was completed, twice as many patients received gilteritinib as the chemotherapy and were followed for response and overall survival. The study had co-primary endpoints, actually. The first primary endpoint was assessed only in the gilteritinib arm, and that was really used just for regulatory submission. That was response rate, the combined complete remission rate and the complete remission rate with partial hematologic recovery. And if that met a pre-specified rate, the study was considered to be positive. However, this was not enough to trigger early conclusion of the study. It was enrolled to completion and followed until a pre-specified number of events, survival events, had occurred, and then analyzed for overall survival. So that actually occurred last summer, and the primary analysis was done once 258 survival events had occurred. And the analysis showed a statistically significant improvement in overall survival in the gilteritinib arm, showing that the study did actually improve survival from gilteritinib therapy. And for this reason, the drug has been submitted and was approved for therapy both in the US and in Japan, and we're waiting to hear on EMA for the treatment of patients with relapsed and refractory AML with FLT3 mutation based on improvements in overall survival. The survival in the gilteritinib arm was 9.3 months, and the survival in the chemotherapy arm was 5.6 months. Now, that being said, these are improvements in median survivals. If we look at the number of long-term survivors, it's still relatively small. So there's still a lot of room to move in terms of what we can do with a FLT3 inhibitor, and that's why we're very interested in combining gilteritinib with standard chemotherapy, and we're primarily doing that in the upfront setting. I'm presenting some data on that also here at this meeting, combining intensive 7+3 chemotherapy for patients fit for intensive chemotherapy with gilteritinib in the front line, using the same dose that we used in the ADMIRAL study. And we've shown that that approach has a very high remission rate and is quite tolerable at full doses of gilteritinib. There's two important clinical take-home points from this study. The first is that targeted therapy is better than chemotherapy that's non-selective. So we should be looking for FLT3 mutations in patients who have relapsed and refractory disease, and that's important because they can change from diagnosis to relapse. So you can't rely on the fact that the patient had a FLT3 mutation at initial diagnosis. They may have lost it, or they may gain it at relapse. And the way we know they might have gained it is FLT3 mutations are associated with rapid proliferation of the leukemia, and often patients whose white counts just zip on up very quickly, those patients are enriched for having FLT3 mutations. So we should be testing for these mutations and then treating patients with a drug like gilteritinib because it improves outcomes, better response rate and better survival in this setting. So that's the first take home. And the second is this is a start, not an end. This is not the fix for patients with relapse disease. We have to prevent relapse, and we have to prevent refractory disease. We have to take drugs that are active like this and move them into the frontline setting. What's encouraging is that the toxicity of gilteritinib really was quite easy for patients to take because it's a well-tolerated drug. We generally gave it in the outpatient setting, and that has moved where we treat patients with, again, very aggressive acute leukemia from the inpatient setting where they might be getting very intensive chemotherapy to the outpatient setting where they're taking a pill once a day. We do see cytopenias from this drug. We do see increases in liver function test abnormalities, transaminases, CK elevations, and there are some rare side effects that can show up, whether it's QT prolongation, pancreatitis, or PRES, which is a neurologic complication, as well as differentiation syndrome, which can be seen in a few patients. These are things we need to look for, but these aren't common side effects from these drugs where we need to worry that the patients might get into a lot of trouble from this drug. It's generally been an easier therapy for patients, and it's really opened up the avenue to treating patients with much better outcomes with effectively less toxic therapy, which has been really gratifying.